Good afternoon, good morning from where everyone's calling in from around the United States. We really appreciate you joining our webinar. This is Medix's second. So we're really excited to present the unanticipated CTMS setbacks and solutions to increase revenue. Our goal today was really to provide you a realistic scenario and approach as we kind of navigate through this webinar. If you noticed, I've been utilizing a chat function on the bottom left-hand portion of your screen to kind of inform you when we were started. I'd also like to let you know that you could utilize that for questions as we go through the course of the webinar. So if something pops up, and obviously we don't necessarily want to be interruption. So please
is now
we'll
exiting.
Get questions at the end. So if you want to email me directly, if you feel more comfortable with that, you can certainly do that as well, and we can address those at the end of the call. So again, we really want to take a realistic approach. We also even tried to add some humor into the webinar as well. So hopefully you all enjoy. So I guess to get us kick-started, let's go through some introductions. Molly, we can start with you.
Great. Thank you, Dan. My name is Molly Downhour, and I am one of the Medix clinical research consultants. I have 18 years of healthcare and research experience and have been a former director of a large phase 1 clinical trial site.
Go ahead, Rick. Rick, you may need to hit *6 on your phone to unmute. It's a function I think that automatically starts when we hit a webinar.
Okay, can you hear me now?
I sure can.
Okay, great. Sorry about that. This is Rick Greenfield. I'm the CEO of RealTime Software Solutions. We provide CTMS products to clinical research investigative sites. And I also have over 13 years experience managing and owning a large multi-site, a multi-specialty research site.
Great. Thank you so much for joining, Rick. We appreciate it. Bridget.
I'm Bridget Gonzalez. I'm account executive at Medix, and prior to joining the Medix team, I was in clinical research for about 11 years.
Thanks for joining. And my name is Dan Dummeroff. I've been in the workforce solution and staffing industry for the last 16 years, and in the scientific and clinical research for the last 9. We obviously wanted to spend as much time on the content, so we wanted to kind of get through those introductions. Just as a quick disclaimer, we partnered with RealTime to enrich the webinar, with the CTMS vendor's perspective. So we're really excited when Rick was able to join. We thought it was going to be a great perspective that he could offer.
Wendy.
So, however, the program is not specific to RealTime or any CTMS. The purpose of this webinar is really to empower the sites and advance the research through shared knowledge and experience.
Dan, if I could also add an additional disclaimer, is that we will use the term coordinators, CRCs, CRNs for clinical research nurses interchangeably throughout the webinar. We recognize that sites have different staffing models, and we use the term that is most common to us.
Yeah, I think that's a great point. That came up in our last, our last webinar. So, I guess let's get it kick-started. Molly.
All right. These are the 4 main reasons why your site administrator has purchased your CTMS system. There is the increased revenue by real-time financial activity tracking, increased protocol compliance, increased operational efficiencies, and centralization of all documents. While these are all extremely important, really what your site administrator is looking for is that increased revenue from financial tracking as soon as possible.
And just a reminder, your CTMS is your tool to accurately account for all activity that has occurred at your site in order to invoice for payment from the sponsors. So research sites run on a reimbursement financial system, meaning that the sites are paid for everything, they pay for everything up front, and then they invoice for reimbursement or payment for the sponsors. So any activity not entered into your CTMS is subject to not be paid.
Bridget, and actually that was a big topic of conversation in our first webinar. So on the next screen, you'll see, part 1. You'll see. I'll send this link out to everyone that's on this call, and make sure that if you haven't seen it, you can certainly go back and view audio and the slide deck as well. So, now that we've got that, kind of under our belt, let's move on to some learning objectives, Bridget.
Yeah, so our learning objectives today, number 1 would be to identify 3 unanticipated obstacles in achieving optimal CTMS implementation and benefit. And then number 2 would be to identify short-term solutions for each obstacle. And then number 3 would be to identify long-term solutions for each obstacle.
Okay, well, let's get into it. Molly, do you want to start with some of the roadblocks?
Sure. Here are the roadblocks that I have experienced firsthand. Number 1, coordinators are stretched too thin to enter the data into the CTMS. Number 2, data entry redundancy. And then number 3, protocol budget amendments held up in negotiations. And often, this is seen most often in phase 1 oncology trials. However, we feel that the solutions that we're offering here today can be applied to all therapeutic areas in all phases.
So as we dig into roadblock number 1, Bridget, can you explain, stretch too thin? Because I think, there's a lot of us that would probably feel the same way.
Absolutely, and it really can't be news to anyone in research. This is so common that the National Institutes of Health National Center for Research Resources launched the Clinical and Translational Science Awards, the CTSA, to improve how research is conducted. And in 2008, the CTSA created a task force appropriately named the Research Coordinator Task Force, specifically to address this problem, as it was identified as a major risk to advance and support clinical research. Furthermore, being overworked was reported as one of the top negative aspects about being a CRC, and many people surveyed listed burnout as reason for leaving their job.
Additional responsibilities that I've had when I was a coordinator, I scheduled patients' plane tickets and other travel arrangements. I did the processing and shipping of lab samples, including going out and fetching dry ice. I assisted with patient stipends and also travel reimbursements. So overburdened staff, they will burn out and leave, or worse, stay and be marginally productive. Turnover and lack of employee productivity is really expensive for sites. Turnover itself can cost $25,000 to $30,000 per employee, not to mention the loss of work that is missed when you're employee down.
Yeah, we've certainly seen this too. Across the nation as we were making placements, so I couldn't agree more. So I guess, how does this relate to the return on revenue for a CTMS system?
So the impact on the data, on the CTMS, is that data is not entered timely. And this is due to competing responsibilities, so items are missed or inaccurate, causing potential delays or even errors in billing. And this also puts the site at major compliance risk when errors occur in billing.
So I mentioned earlier we're going to, infuse some humor into this. So when we were, kind of preparing for this webinar, I was actually making a statement to the group saying, hey, it blows my mind how overworked the CRCs are, and look what Had It Marketing found me the perfect slide. So it was funny. But in all seriousness, what are the common, Band-Aids I guess both of you have seen been used?
Dan, this is a great question. So a Band-Aid that I have seen is to have other employees enter the data. We discussed in our last webinar, the CRCs are the ones doing the work, or the CRNs. Therefore, they have the best knowledge of what was done. If other employees enter the data, the coordinators then need to still go back and verify the accuracy. So the more hands in the process, the greater opportunity for error. I like to say, always stick to the lean process.
Absolutely, and another Band-Aid was to download the visit sheets from the CTMS, print them out, and have your CRC or CRN complete them on paper, and then hand them to the finance team to enter into their CTMS. This is definitely a temporary solution or Band-Aid, but we did use this while retraining and re-educating staff. Unfortunately, it does end up taking more time, and it is redundant work.
And yeah, this is Rick, and I completely agree. I mean, this is an opportunity for managers to really stress the importance of that real-time data entry into the system, and that data entry should not be optional. It should be something that is required. Of course, losing track of that real-time data can create even more work to go back and rebuild the data at a later time.
Yeah, so that's a great point, to everyone. So, if we look at some realistic solutions, what can we talk about on this call?
So a short-term solution and a priority fix is that as a site administrator, you need to ensure that your investigators are not over-delegating.
Yeah, I've definitely met my fair share of investigators, and that sounds easier said than done. So I found it almost being a job.
Is now joining.
Luckily, that wasn't my situation, but I have seen where that's common. The ammunition you need to help persuade them is on the FDA website. They have warning letters and responses that you can use to back up your position. Not to mention, you have the $25,000 to $35,000 cost in employee turnover. You need to speak their language by using supportive data.
So that's a good point. I mean, I guess that wasn't your situation. So what about the overburdened staff where the PI wasn't over-delegating?
Okay, so in this situation, my coordinators and I made a list of all the essential tasks the coordinators need to perform, and then another list of the non-essential tasks. We delegated out the non-essential tasks like tracking down medical records, scheduling patients, getting insurance authorizations, shipping samples, to existing support staff such as medical assistants, medical records, and research assistants. I mentioned before I used to go out and fetch the dry ice. We looked at other supportive sources of having a vendor come and bring that in. So there's not only support staff, you have supporting resources. Then as my site grew, I proactively and strategically hired staff to keep everyone working at the top of their scope. So my next hire after coordinators was a designated regulatory affairs person. And then to help support and offload the burden on my research nurses, I had designated infusion staff. After that, I added project management for contracts and budgets and so on and so forth.
And adding layers like that to your team also provides for career growth, which is an important component for employee retainment as well. So remember, often administrative staff can be built into your startup costs and even your study budgets, as these are hard costs.
Yeah, that's a good point. So Molly, can you kind of tie it together for us?
Sure. To ensure your coordinators have the time to enter data into the CTMS in real time, they need to be positioned with the time and supporting resources to get it done.
So being a little bit of an outsider here, I'm picking up on two main takeaways. It's certainly have the coordinators work at the top of their scope by delegating appropriately, and then make sure that they aren't overburdened by PI overdelegation.
Yeah, and I think it's what I like to say is we want our coordinators to coordinate. So those less critical functions need to be delegated to other personnel.
Is now exiting.
And so I think we want the CRCs to manage that data in the CTMS and make sure that they have the bandwidth in their schedules to do so.
Well, thanks. So let's move on to roadblock 2. Bridget, can you get it started?
Yeah. So roadblock number 2 is data entry redundancy. So it's a fact. Patient databases are growing rapidly, and EMR systems do not always communicate to EDC systems and vice versa. Sites can have up to 15 to 20 different EDC systems for their trials. And then don't get me started on uploading forms or printing records, redacting them, and then shipping them off for remote monitoring. Anyone overwhelmed yet?
Can I get an amen?
Amen. We told you about that humor.
Sadly, there's going to be some data entry redundancy. It's research, it's the nature of our industry, but with no good solution as well. But let's address the things within our power to change.
Okay. The impact is obvious. It is needlessly time-consuming. You've got the risk of decreased accuracy and the decreased employee morale. So here's a little story. Once I did a process walk with an organization's IT team to show them the multiple systems and redundant data entry that the research team goes through on an average day. So by noon, we had already used 16 different systems and entered the same patient demographic information on one patient 4 times because the systems were not connected. Sadly, this had become so much of the norm that the team didn't even wince. But when I saw it written out on paper, it was mind-numbing, or as we said before, it blew my mind. Just the waste and the multiple opportunities for error. The obvious goal is to have one source of truth where the data is entered one time. So while this is improving with the major EMR systems like Epic or Cerner, you're still looking at creating interfaces with your CTMS system and any other outside system you're using. So some of the obstacles here, you have small research practices that may not have the capital to add these features on when purchasing the systems, or you have research programs in large organizations that are often having to compete for IT resources for these to be put into place.
So the impact was big. It was big. So what were sites doing?
So it's just one more thing. How many one more things can they do?
Yeah, I had to hire someone to ensure that everything was correct just because the systems didn't connect. And then unfortunately, because it was really our issue, I wasn't able to put that into our study budgets for reimbursement.
Yeah, so I guess, can we talk about the, some realistic solutions then?
So, well, the obvious answer is to eliminate any unnecessary tasks and get down to one system of truth. And most CTMSs have this functionality. One of the mistakes that I made was I resisted to use the CTMS functionality for site metrics. I had a long history of the system that I had used, and I had all my data in that one place. And then this can also be applied to patient screening.
And if you can't have one source of truth, the next best long-term strategy is to really look for ways to get a direct data transfer or interface where you're only having to enter the data once.
So that's a good point. But, so Rick, I guess what are the questions, what questions should a site administrator ask their vendor to help reduce some of this data redundancy?
Well, I mean, it is a good question. Data redundancy is a huge issue in our industry in general. There are some opportunities for systems to interconnect. Some of the EHR systems can talk to CTMS systems. So I think when looking at systems, it's a matter of asking about what those interconnectivity capabilities are, and then talking to the vendors about what it's going to take to get those connections put in place.
And the last long-term solution is to really incorporate budget fees for redundant data entry for sponsors. It's really not a cost of doing business to enter data onto logs when it already exists in your EDC. We once had an EDC for a clinical trial where the EDC asked for the same information 4 times, 4 different places, and then, of course, then we were queried and quadruplet for that. If all sites encourage sponsors and CROs to really try to minimize redundancies, we can all save time and money.
Well, great. That certainly ties up some of the solutions. So to stay on point as we're moving through this webinar, let's talk about our final roadblock. Bridget, what do you mean by the delayed budget amendments?
Right. So this issue was more of a problem when I worked in a phase 1 oncology clinical trial. However, like Molly stated, that it is the solutions here can be applied to all indications and phases as well. Here are the reasons for the delay. One of them being sponsor or CRO representatives have moved to other responsibilities. So the person that you were negotiating that original budget with is no longer the representative you'll be working with. And then number 2 would be limited time on both parties to negotiate the new amendment. It is a fast turnaround, and so it is time is of essence. Number 3 would be sponsor and CRO representatives. They don't realize the impact that the delay on the site, for the delay on that site.
So we're definitely seeing some reoccurring themes. Overstretched staff, and it's not a priority for them to work on. But Bridget, I guess what is the impact of the delayed budget amendments on the sites and their CTMS?
So it could be a huge impact. The site must implement the protocol amendment upon IRB approval, and this is subject to your SOPs or policies and procedures. But they do this to eliminate safety and compliance issues. And this is regardless if the budget for the amendment is approved.
So I guess, what does that really mean?
So it means that once that new protocol amendment is implemented, the site must add or remove those procedures that may not be negotiated yet and begin to track unconfirmed revenue. So sites then have to go back and backfill that revenue and adjust any guesstimates or zeroed out procedures, which is increasing their risk for error. And billing is also now on hold, which further delays site reimbursement.
Okay, so I get it. So I guess if the amendment isn't up to date, you're doing the trial but not able to bill.
Absolutely.
Okay.
So,
I guess from there, what do we do?
Right. So Band-Aids we've used in the past, we're holding off entering the data. Of course, you're not holding off on any of the procedures, but the data into your CTMS until the budget is up to date and retroactively enter the data.
So obviously, delays in entering the data is not ideal. As the further away from the date of activity, the increased likelihood of not remembering the information, leading to mistakes in entry, over and under reporting. I mean, I have trouble remembering what I did 2 days ago, compared to 6 months ago. That's even worse.
I can second that.
So in phase 1 oncology trials, I've had budget negotiations delayed on amendments by 6 months, and that crossed over multiple amendments. So it was very confusing for the staff to try to remember what occurred on each patient, on each amendment, since it had occurred so long ago.
And Band-Aid number 2 is to keep calling, or as we call it, smile and dial. You'll often hear no update, or it's still with legal, and then you really start to question, am I being a nag, or are they avoiding my call?
Yeah, I mean, it almost seems like a no-win situation. So I guess what can some of the sites do?
So a short-term solution we've used in the past was to build the budget amendment into your CTMS so that you're ready as soon as that protocol amendment is IRB approved, and again, according to your site SOPs. But for any additions or procedures that were already agreed upon in your original budget, you can add or delete this same amount. And then for any procedures that were not previously agreed upon, you can enter a 0 and adjust the accrual once pricing is final. The biggest part is to go back and adjust your accrual.
Yeah, and that is what we definitely recommend to our clients as well, is that we want to get as much data in now as we possibly can. Use your best guesses. So if you've already negotiated the pricing on prior procedures, you can, pretty much guess that those same prices will be in place if you have to add those in or take them away, for that matter, into additional visits. And something that a lot of sites don't realize is that the CTMS vendor might be able to help with some of the back data entry. So if you, like you said, Bridget, if you're putting 0 values in for a procedure because you're not sure what that revenue is going to be until you negotiate the amendment, it's possible that your CTMS vendor could even go in and script that on the back end and plug in that price once you have it, instead of having to go into each and every visit and enter that manually.
Yeah, that's a great point. So it sounds like the data entry can still be done in real time, which will, certainly keep it accurate, but you're still on hold for billing.
That's correct. So let's move on to a long-term solution for you, which is increasing your chance for success, and that's to add contract language to give a time limit on renegotiating budgets, so maybe 2 weeks. You can support this language to say that it indicates safety changes have to be made in real time, and this clause is necessary to keep billing and current and accurate.
So it seems like a reasonable request overall. So I would assume some of the amendments are small changes then.
Yes, some are, but there's others that can have multiple new arms. The good news is that many times the pricing of these assessments hasn't changed, so that doesn't need to be renegotiated, only new items.
Okay, great. So, we are perfectly on pace, which I love. So as we summarize the last few points, remember, I've got a few emails already sent to me with some questions, but if you have some questions that you'd like to ask as well, make sure you put them in that chat function. So I guess as we wrap this thing up, in 20 seconds or less, how would you summarize the strategies here to maximize your CTMS and certainly keep the revenue coming in?
So keep your coordinators working at the top of their scope so they can enter data into the CTMS daily.
And for me, use your CTMS's functionality for metrics and screening rather than recreating the wheel. So don't let entering that important data slip. The accuracy, the completeness of the data will suffer and result in a lot of rework. So, kind of to the point of try to make sure that you're always keeping your CTMS up to date in real time.
And I would say to incentivize your sponsors and CROs to turn around budget amendments quickly to help avoid the data redundancies with proactive contract and budget language. Just overall reduce data redundancy.
Yeah, that's great stuff. I mean, these are all great points. And before we kind of get to the questions part, I want to make sure that I thank our entire panel for being on the webinar. We really we really appreciate it. We know that you're busy. And we've had, several other people from across the country on this, so I know, the appreciation is everywhere. So, again, if you haven't had a chance to tie the two webinars together, I'll be sending out the first one and the second one with the slide decks and audio for the first, the end user engagement, so on and so forth. So, again, I've got a few questions that were emailed to me. I'm going to start with them, and again, if there's any other things that need to go into the chat function, or if someone doesn't mind speaking up, you can certainly do that as well. So, let's get to this first email that was sent to me. What is the biggest unintended impact of embracing the CTMS?
So this is Bridget, and I would say amendments, the protocol amendments and the impact that they have, I would say was the biggest unintended impact.
For me, I was really taken back of the lack of or the hesitancy in the end user engagement. I really didn't realize that there was such a conflict that nurses felt of doing anything financial. And so to refer back to the first webinar, finding out that there's actually research published on this and how to help them overcome this, that was a big deal and a good learning experience for me.
And being a CTMS vendor myself, I think the biggest thing that I see a lot of times is that sites don't realize that when you implement a CTMS, that oftentimes you'll have to make some modifications to your business workflows and business rules. A lot of CTMS systems, or really pretty much all of them, are out-of-the-box solutions. And so while some customization may be available, you do have to sometimes modify your business rules or your workflow systems to really work well with that CTMS system.
Okay, awesome. So it looks like that question came in. So thanks for putting that question through. The second question I have is, what was the pivotal point in seeing the value in the CTMS system?
For me, this is Molly. I was surprised of how much money my site was leaving on the table with trying to do this through a manual system, relying on the staff, the coordinators, to remember everything that had occurred in the prior month and report that data. So as we were implementing it, I was already seeing small wins of increased revenue being collected.
And
Rick,
I can jump in here. Yeah. So I think for me, I obviously have been a part of a lot of CTMS implementations, and I've seen those implementations go very quickly and be very successful in a short period of time, literally within weeks, where people are starting to see some of the benefits that Molly's describing as far as, seeing the money that's been left on the table all these years and really making sure that they're collecting every penny. Of course, I've also seen worst case scenarios where the staff, the management just doesn't really embrace this new technology. They don't, and I do believe this at the end of the day becomes a management function where the managers have to really be strong and encouraging and endorsing the CTMS to be implemented at the site. And so I've certainly seen complete failures to launch and everything in between. So, my suggestion is to really get hard-headed and say, we're gonna make this happen. We're gonna embrace this technology, and we're gonna get it implemented for our benefit.
Great, thanks for that perspective. I have a few additional questions, and we'll try to keep it rolling here. But I guess what was your CTMS journey like?
I will be honest and say that hindsight's 20/20, and I think the first one is always, well, for me it was the most painful one, but at the same time, hopefully for those of you who are out there that you only will do one, that you will get a system that you enjoy and that works out for your site. But I think now that I have more tools to help me do it for the next time around.
Okay. So one last question that kind of came in was, and again, we may not cover this, but it was, we can certainly reach out to Rick after this, and if Rick's not the right contact, I'll certainly point you in the right direction of someone. But it was, will your group be presenting on the CTMS for the sponsor use? We didn't necessarily cover that today. So I think, Rick, I may be able to connect you with some folks after the call, and we'll certainly take note of that as well, and certainly, cover that, down the road.
Sounds great.
So without further ado, that kind of concludes our webinar. So thank you, so much. We are having, we are going to be conducting a third webinar next quarter. So it is going to be research careers for nurses. So we're excited, about that. And again, thank you to the entire marketing team that helped us put this together. Thank you to the entire panel. Please reach out to me if you have any questions or thoughts. We'll definitely get you connected with the right people if some of the information wasn't covered today. So thank you very much and have a great day.